In Essential Task 912, we are going to describe the treatment techniques used in cognitive therapy. Cognitive therapy is going to harness the idea that the disorders that we've been talking about and the symptoms are a byproduct of the thinking process or the thought process of the patient. In today's Essential Task, we're going to talk about two different techniques that are classified as cognitive therapy and do the three boxes that you see here under the broad category of cognition or cognitive. I'll allow you to pause the video here before proceeding into the concept map. So in the previous Essential Task in 9.11, we talked about behavioral therapy, the idea that we can essentially reteach certain new desirable target behaviors to the patient through a variety of different techniques. Cognitive therapy, on the other hand, believes that the disorders and the symptoms in question are a byproduct of the patient's thinking, and if we can fix the thinking process, we might be able to alleviate symptoms. Cognitive therapy tries to teach people new ways of thinking and interpreting, assuming that the thought process is the underlying cause of the symptoms. So, for example, a cognitive therapist might, for example, look at an anxiety disorder such as a phobia and believe that the patient has some type of distorted misinterpretation, flawed thinking process in regards to the phobia in question. An individual who classifies as a cognitive therapist would apply that same standard to virtually all of the disorders from this unit. Essentially, what a cognitive therapist does and believes is that patients exhibit what are called cognitive distortions, which are irrational thoughts, particularly irrational thoughts that tend to influence our emotions and our behavior, and that if we can fix those irrational thoughts, again, these cognitive distortions, through a process known as cognitive restructuring, the patient can walk out of therapy with this new frame of mind, this new manner of interpreting the world around them, and maybe potentially see a reduction in their symptoms. For example, a statement such as, if my wife doesn't say goodbye, then she doesn't care for me or she doesn't love me. That's a statement that a cognitive therapist would classify as a cognitive distortion because it's simply not true. And if that type of thinking is persistent in your behavior, that in and of itself might produce some symptoms of a disorder that we talked about prior to the essential tasks regarding therapy. If you think, for example, if I do not receive student of the month or employee of the month, that I'm a failed student or a failed business person. Well, that's also not true. That is an additional cognitive distortion. Any thought that is simply not grounded in reality, not quite a delusion, we're not getting to the level of schizophrenia delusions here, but those types of thoughts that I'm talking about, that you'd be a failed business person or a failed salesperson if you do not win employee of the month, are examples of the types of thinking that cognitive therapists are keenly aware of and are trained to identify and then subsequently fix through a process called cognitive restructuring. Just to give an example of a type of question the College Board has used, let's say, for example, you think to yourself, I really need to go to the mall. There are sales today that if I miss, I'll never be able to go back and get. Well, that is true. That is a statement that is generally speaking true. There'll probably never be exactly the same sales on this particular day of the week or this particular day of the year, assuming it's a one-off sale. So that isn't a cognitive distortion. But if you tell yourself, if I don't go to the sale, I'll never be able to get great clothes again, well, that's a little bit of a different story. That thought process is misinterpreting this opportunity, overgeneralizing it, doing what some of the cognitive psychologists that we're about to talk about would classify as catastrophizing. And that in and of itself might be producing some of the symptoms of a disorder that we talked about prior to this essential task. But we'll talk about two different manners of achieving cognitive therapy. And the ultimate goal, regardless of which of the two that we're talking about, is to do cognitive restructuring. Make it so that we identify these irrational thoughts and replace them or restructure them into much more rational thoughts. The first is our new friend, Albert Ellis. Albert Ellis is responsible for developing a form of cognitive therapy known as rational emotive behavior therapy. Now, don't get confused. The word behavior is in fact in the name, and that is a little bit confusing because this is not a behavioral therapy. So do not see that word and connect it with the prior essential task. That's simply not true. Think about it if it makes it easier for you as the abbreviation REBT. That way the B is no longer shown as simply the word behavior. But REBT, or rational emotive behavior therapy, is a confrontational form of cognitive therapy where the therapist on purpose both challenges and disputes the validity of the patient's cognitive distortions. And this can be incredibly confrontational. If you think back to when we first talked about insight therapy and specifically talked about the Carl Rogers client-centered approach with the active listening and the rewording and the head nodding, That was a very gentle type of therapy. And for some people in some disorders, under some circumstances, that's really beneficial. That is nothing like what you will see with the Ellis technique. Ellis identifies what he considers catastrophes or examples of catastrophizing, identifies them, and is fully willing and able to critique them and try to attack the validity of those distortions. So if you said, for example, to Albert Ellis, if I don't go to this sale, I'll never buy any good clothes again, Ellis is willing to point out that that's simply untrue. And he's not going to hide it. He's not going to coax it. He's not going to shield it in anything. He'll tell you bluntly that is simply not true. You're making a catastrophe out of this. And he's willing to confront you. And in some cases, that type of back and forth can be a little bit more combative than you might anticipate in a therapy environment. I want you to watch this clip here. It's actually another clip. If you begin at the 10:30 mark with Gloria. Gloria was the woman when we first looked at the Carl Rogers technique of active listening, who was talking about now that she's single and no longer married, how that's going to affect her dating life with her children. You'll see here that exact same woman talking about the exact same topic with a totally different psychologist or therapist, in this case, Albert Ellis. And you'll see how Albert Ellis is totally willing to confront what he finds to be cognitive distortions or catastrophes or examples of irrational thinking, tries to challenge them, tries to refute them, and it can get a little bit combative between him and Gloria. When I look at the name of this term, rational, I see the AL at the end of rational, and I think of his name Albert, or the AL in Al, and that's how I've always connected the AL in rational to the AL in Albert. But that's the first technique that's classified as cognitive therapy. Let's clearly confront these cognitive distortions. Let's not hold back. Let's be blunt and honest. If we think the patient is making an irrational statement, we tell them that, we tell them why, and maybe we can deconstruct these irrational thoughts. The other end of the spectrum is Ehrenbeck's CBT, or cognitive behavioral therapy. Again, don't get confused by the fact the word behavioral is in this. CBT can be a little bit complex in the sense that if we actually practiced it or looked at it, there are a lot of elements to it. So I'm going to try and simplify it down to this. Think about what we just talked about with Albert Ellis, the previous box. Ehrenbeck tries to do the exact same general thing, but it's way less confrontational. The Ehrenbeck CBT, or cognitive behavioral therapy, approaches the deconstruction of cognitive distortions in a much more gentle manner. So, for example, Ehrenbeck might ask you a question like this. What is the worst thing that can happen? Let's say, for example, you have anxiety talking to strangers. And you, as the patient or the client, might say, well, I'll break down and I'll be unable to respond and I'll get really nervous. And then Ehrenbeck might respond, well, what's the most likely thing that's going to happen? And for some people, the most likely thing is that you get through the conversation and it's uncomfortable, but you don't break down in front of the person. And then Ehrenbeck will say, what's the most desirable thing that can happen? And the patient might say, oh, well, I'll get through the conversation flawlessly. But for some people, when they start to realize that the worst case scenario is not the most likely case, that in and of itself can be beneficial, because then what he'll ask is, even if the worst thing happens, will it matter in a week? Depending, the answer to that might be yes or no. If it's talking to a stranger and getting nervous, will it really matter in a week if you never see that person again? No. Well, then if it does, maybe it's someone that isn't a closer social group to you, he'll ask, well, will it matter in 6 months or a year? And eventually the answer to that's going to be no. So by doing that, it's not confrontational. It's nothing like the Albert Ellis technique. It's kind of a guiding way of allowing patients to realize that their thought process is distorted by asking these types of questions. Will it really matter in a week? Will it really matter in a month? Will it really matter in a year? And the hope is that a patient who, for example, is experiencing social anxiety disorder walks away from therapy and says, you know what? Even the worst case scenario is not going to matter in at least 5 or 6 months. So maybe the anxiety that I feel talking to strangers isn't warranted. Maybe I need to reassess my thinking process and change this cognitive distortion, this nervousness around strangers, and replace it with a much more rational thought that I might not enjoy talking to strangers, but even if something undesirable happens, it ultimately won't matter in the long run, and that I should be more comfortable talking to strangers. And then perhaps that in and of itself might be a sufficient treatment method and alleviate the symptoms of, in this case, social anxiety disorder.